I am so happy today to be welcoming Dr. Dianne Atkins for an episode of Shok Talk. I'm Allison Shok.
And I'm Richard Shok.
Dr. Dianne Atkins, I'm going to take 10 seconds to talk about how special you are and how awesome it is to have you. She is a pediatric cardiologist. She was named a 2025 ILCOR Giant and has served as the ECC chair, creating guidelines for CPR guidelines from the American Heart Association. So amazing to have you.
Thank you. Thank you very much.
We are here today. We want to talk to you and learn about you, but we also are so curious to learn about AHA and ECC guidelines. As veteran CPR instructors, I think we've both had the experience of, new guidelines are coming out. Here they come, without any real knowledge of the work, the hard work that's done in the background to make it happen. And it's something that's fascinated me for years. So to have such an expert, it's going to be so exciting. And I'm really looking forward to that today.
Me as well. This will be my, the 2025 guidelines coming out in October will be my fourth guidelines change. So I know that doesn't sound like a lot, but I think it's pretty significant.
Well, let's start off with just a little bit about yourself. I gave the high level intro, but I would love to know a little bit about you and what first inspired your work in resuscitation.
Well, my work in resuscitation actually started with a telephone call many, many years ago from Dr. Richard Kerber. Dr. Kerber was actually one of the founders of emergency cardiovascular care. He was an adult cardiologist at the University of Iowa, where I was a pediatric cardiologist. And he did some of the founding work, some of the basic work on defibrillation, pad placement, transthoracic impedance, did body weight, chest size, chest configuration. Did that make any difference in how well a shock would be delivered to the heart? And so he called me up one day and said, "What do you know about transthoracic impedance in children?" And I didn't know a thing. And he was very kind. And when I paused and didn't answer him right away, he went on to explain to me that was the impedance of electrical flow through the skin. And as part of his work to figure out if body size or chest configuration or anything like that made a difference, he asked me, would I be able to measure that in some children? And it was a fairly easy first project to do. And by the time everything was said and done, we had actually done 3 studies on this in children. And that's what got me going just on those papers, because there wasn't really a lot of scientific literature on defibrillation. There was Howard Goodkessel's initial paper back in the 1970s that sort of set the 2 joules per kilo, but in today's scientific environment, it really was not, it would not be considered a high quality study, but at the time, it's all we had. And based on that, I started getting questions and then was appointed to one of my first guidelines, which was back in 2000, to start working on, the questions around defibrillation. And from there, it just continued and my role just kept getting bigger and bigger, which I enjoyed immensely.
That's awesome. Can you explain a little bit? You touched on it. Your position within ECC guidelines grew. Could you mind giving just like a very high level of like what they are and then what the roles within the committee look like?
So the ECC guidelines are a science-based, evidence-based assessment of what works best for resuscitation for both out-of-hospital and in-hospital cardiac arrest. I think that's the highest level overview of the guidelines. We published several documents in relation to that. One is the guidelines themselves, which includes a lot of the science review, and we can talk about that science review in just a minute. But that includes the science review with all of the references for the um, scientific papers that are evaluated to um, develop the guidelines. And then from those guidelines, we develop the teaching products. And that's what our instructors in the teaching centers use as they teach CPR, ALS, BLS, PEDS, neonatal. And so they're at two different levels. There's the actual guidelines, which is a scientific summary of how of what was evaluated and how the decisions were made, and then the teaching products that come out from that.
Now, guidelines are made every 5 years as a complete overhaul, complete review that comes out. Why 5 years? Why not, like, when a new study comes out, why would you not, like, immediately change something?
Well, we actually, about 10 years or so ago, we did start doing exactly that, Rich. We do a comprehensive review of everything every 5 years. But there is an update that comes out in the fall of every year, which will take on a few very specific topics for which we know there is a lot of interest in the resuscitation community, or there is a new paper. Um, and now those are much shorter, and they usually only encompass 3 or 4 questions per section, for ALS or BLS or PLS. But then we really want to make sure that we have covered the entire scientific literature. And that's why we do the every 5-year review. And those are very extensive, very thorough and complete literature review. We actually have professional librarians or information specialists who help us search the literature and just to make sure that everything is covered. And that's why we do that every 5 years. It's a huge task. We couldn't possibly do it every year. And for better or for worse, the science isn't produced that quickly to make it worthwhile to do it every year. But we do, if there is something that is very important, say like temperature management, airway management, dual sequential defibrillation is a good, very current example. Then we will publish something annually on those topics.
Would you speak a little bit more to who the we is in part of the committee?
Well, it's made up of a lot of volunteers for the American Heart Association. People apply to be members of the Emergency Cardiovascular Care Committee. That is the overall committee. And then there are multiple subcommittees under that. There is the Science Committee, the Systems of Care, and then the Education Committee, subcommittee. And people apply, and their background, their publication record, their specific interest, their specific expertise is evaluated, and then we choose the committee members based on that. And we're in no way only looking for physicians. We want nurses, we want respiratory therapists, we want hospital administrators, we want IT people. And so we want a broad cross section of all those. We want EMS people, out of hospital, in hospital, critical care, all of that, to make sure that we have the whole field of resuscitation represented on the committee. And then when it's time for a 5-year review, 2 to 3 years in advance of that 5-year review, we start developing writing groups. And many of the subcommittee members are on the writing groups, but not all. The writing groups are made up of again a broad swath of expertise, and so there will definitely be people who are on the writing groups um, that we may reach out to and say, because of your particular expertise, we think it would be good for you to participate in on one of the writing groups, and we try and keep those fresh so that there's some continuity because a institutional memory is good, but we also want new people with new ideas. So if you look closely at the lists, the authors for those writing chapters, you'll see that there are some very familiar names, but there are also some very new names. So we try and keep that moving. Uh, and that's a little separate from the actual subcommittees of emergency cardiovascular care. Um, the other thing that we closely look at is potential conflicts of interest. Um, the writing group chair and co-chairs can have no financial interests in the topic that they are writing about. So no speaker bureau, research grants, um, those kinds of things to make sure that the science is fairly evaluated.
Very good. Very good. Now, do you all get together in person? Is that how it's always been, or is it like lots of Zoom meetings and like how is that happening?
It's definitely a combination of both. We did the 2020 guidelines and a lot of Zooms, um, but it's a combination of both. I would say there are probably monthly Zoom meetings for each chapter in the guidelines, but then at least oh probably 5 or 6 times in the 2 year period they actually do meet face to face, usually in Dallas, where the headquarters of the Heart Association are located. Um, and they will meet for 2 days and sort of hash through because the guidelines are uh, they are evidence based, but sometimes the evidence is not as strong as we would like, and then it's a consensus. And so there are sometimes very prolonged discussions about the interpretation of the science, how that will affect the um, training community, how it can be implemented. And so there are very, very definitely, probably in the overall process, at least 5 or 6 um, face-to-face meetings, which will be about 2 days. So they're intense. They go all day.
I believe that.
I think that's one of the things I was most interested in was how strong is usually evidence and the ability to reach consensus as you guys are looking at the newest studies and newest results and then deciding which way to guide the general public and those that are using these guidelines.
Well, sometimes it's reasonably easy. One of the things is that if there's no new data, we're very hesitant to change a guideline. We really like to change guidelines only because new data is available to evaluate. There are some things that are pretty controversial. And although we will come up with a guideline in the document that comes out in circulation, the discussion will be recounted as to what how we came to a consensus and the differing thoughts and recommendations will be discussed. So we try and be as transparent as we possibly can. We don't want people to think that we are making these our decisions arbitrarily, and we don't want people to think that it was the loudest person in the room, because it really is not that. We have to come to consensus, and everybody needs to agree at the end of the process that this is the best route to take.
And I believe you had previously, before this call, had shared there's ways of the different chapters and groups, they kind of double check behind each other. Everyone's kind of dipping their toes into each other's.
Absolutely. We have a couple of people that we call senior science editors. They are actually, it's the one area besides the AHA staff, but these are actually paid consultants for the Heart Association. Everything else is volunteer. But the senior science editors are responsible for making sure that there's not gross differences in any of our guidelines. Like, we certainly don't want any differences between recommendations for CPR in the ALS guidelines that differ from the basic life support guidelines. It becomes very important in the issue of children. The pediatric guidelines, we say, go up to the age of 12 or to when a child has signs of puberty. But that's not the easiest thing to tell, especially quickly. So we want to make sure that that those guidelines, especially for like defibrillation, drug dosages, fluid rates, those kinds of things, make sense for that transitional population, those young teenagers, basically. And so that's one area that we look at very, very closely.
Very cool. I remember, probably 2015 guidelines and how far-reaching that, the work that you all do really takes. And I still get people that come up to this day that are like, oh yeah, like you're not supposed to give breast anymore. And that was like one of the big take homes, I think, from the 2015 release, because like the news media and lots of outlets picked up on that. And the true guideline was around de-emphasization of rescue breathing, particularly for untrained rescuers. But the take home message seemed to be, breasts don't matter anymore, just do compression only. And that's what everyone seems to remember. Do you have any thoughts around that? And what are the other kind of like big far-reaching changes that you've experienced when you were doing some of the editing?
So that decision to go to hands only for lay rescuers, okay, so it's really mostly for lay rescuers, was based on some very strong science. A lot of it came from the University of Arizona, showing that especially in the initial moments of a cardiac arrest, for adults, this does not apply to children, and it has to do with the differing etiologies of pediatric and adult cardiac arrest. But especially for adults, the most important thing at that moment is to get the blood circulating to the brain. And what we know is that it's a whole lot easier to resuscitate the heart than it is to resuscitate the brain. In a cardiac arrest, the brain has immediate ischemic damage or potential, and you really want to get blood that contains oxygen to the brain. If somebody has a sudden cardiac arrest out on the street or something like that, their body is fully oxygenated. And so you want to get that blood quickly to the brain because there's oxygen there. We don't have to supply oxygen. It's already there. And if we do hands only, then we can get that oxygen to the brain. Because most people who die a couple of days after a cardiac arrest die because of brain damage. Okay. The heart has pretty immense capabilities of recovery, but the brain does not. And so it's this emphasis on getting blood to the brain. Now, for children, that's not the case. We still strongly recommend breaths with children. There are several papers from both the United States and Canada and Europe showing that children do better if they are given breaths in the immediate first initial moments. And because a lot of them have a long prodrome prior to their arrest, they have respiratory disease often. And so they are starting to become hypoxic and acidotic before their heart actually stops. And so that's the reason why we do recommend that for children. Now, in a prolonged resuscitation, absolutely, you have to start doing breaths because you will the body has been depleted of oxygen and you have to provide something. But often you can wait for the professional rescuers to come do that. But the hands only is primarily for lay rescuers.
Mm-hmm. Yeah, it's just as Rich said, it's been so interesting to see what, like, there's so much nuance and thought that gets put into it, and then sometimes just a snippet, the 5 seconds that the general public hears, and frankly, even medical professionals do.
That's very true. Mm-hmm.
I am ashamed to say that, as you know, when I was just working as a nurse or a CPR instructor, I was just like, okay, you're handing me something new. What do I have to learn now? Which is a shame because there's the science evolves, and if we don't evolve as practitioners, then we're not going to move the needle in anything medical. But cardiac arrest seems to be something that's really hard to move the needle in.
It is. It's very hard. When I talk to the public and the lay rescuers, I tell them that I am unaware of any medical disease which requires therapy within the first several minutes of onset to have a successful outcome, which means that basically you have to have bystander CPR or lay rescuer CPR. Somebody who's right there can start CPR right away. If you don't have that, then our EMS providers, there's already been a big delay. There's already been some ischemic damage to the brain. And then if there's not, the people in the hospital are really not able to overcome the lack of treatment in the first several minutes. And that's one of the reasons why I think it's very hard to move the needle. It's obviously an incredibly serious process to begin with. There's a lot of potentially underlying comorbidities, but it requires that immediate treatment, and without that, the likelihood of a good outcome goes down very fast. Mm-hmm. Which is why, one of the big emphases of the American Heart Association is widespread CPR training. Our biggest is making sure that everyone who graduates from high school has been trained in CPR.
Absolutely.
Ideally, we'd like people to have refresher courses, but we know that if you've had even just one course in CPR, you are more likely to do CPR even 3, 4, 5 years down the road.
I absolutely love that. And, we see, some of the science around the educational response with CPR training, with the resuscitation quality improvement program where, healthcare providers are getting quarterly hands-on, low-dose, high-frequency practice. But then we'll have somebody that comes up to us, that'll be in their 40s, and they'll say, oh, yeah, I learned how to do it in high school. I don't need to practice when we're at like a community event. But it's really important that we're getting out there and we're really focused on getting as many people to learn as much as possible. I do a lot of work as a volunteer for Citizen CPR Foundation's Heart Safe Communities program. Mm-hmm. And through that, one of the designation criteria is to have 15% of your population trained or exposed in some way to hands-only CPR. So really important that we're getting as many people out there, and we see, the science behind like CARES and everything, that when there are more people that have the training, they're more likely to act in an emergency situation. So we'll hope to keep those numbers up.
And one of the things that is really even if you haven't had the training, dispatch CPR has been shown to be very, very effective, on the spot teaching, telling somebody, how to do CPR in the thick of it. And that's been, our dispatchers are amazing. There's no other word for it. They keep their cool when, the person on the other end of the line is freaking out. And it really does make a difference. So obviously we want to teach people CPR. We want them to have that experience. And the practice is very important. You can't just think it. You have to practice it. And that's why, our hospital providers, especially our intensive care providers, we do have this, high frequency, short interval, short time training, because of that. The muscle memory is very, very important. But the second thing is dispatch CPR, and that actually also has been shown to be very, very important.
Yeah.
I find myself so interested as we keep looking at the chain of survival and just how integral each link is, because, we can get to the hospital and do every bit of the ACLS algorithm, but it's true, just the most basics of call, push, shock. If those things don't happen in the beginning, we can get so detail oriented, and which drug are we doing when, and what order, and what dosage per kilo. And those are so important, but also that the outcome is so dependent on those first few minutes.
When I talk, and I do a fair amount of talking to the lay public, I emphasize that the first 3 steps have to be provided by a lay rescuer. They have to call 911. They have to start CPR, and they have to defibrillate if they can locate a defibrillator. And those are all things that are done before any professional shows up. But they are probably the 3 most critical links, because if you've done those, then the job of the hospital personnel suddenly is fairly straightforward. If those have not been done, then unfortunately it's also fairly straightforward, and usually you keep things going for we'd like for 3 days. Sometimes something may happen before you have to declare that this person is not going to survive or is brain dead.
We touched on the changes that happen, the way that the measured research conversation, but what happens when something like COVID gets thrown into the mix?
Oh, that was a biggie. That was huge. And if you go back and look at the guidelines, you will see that we published 3 documents early on in COVID. And it was tough because we didn't know what we were dealing with. All we knew was that we had this horrible virus that was killing people. And suddenly, for the first time, we were as concerned about the person who'd suffered a cardiac arrest, or we were as concerned about the providers as we were about the person who suffered the cardiac arrest, because it was a huge issue for our out of hospital responders to respond, and they had no idea, does this person have COVID or not, and what does that mean? So we had to make some pretty big changes in the guidelines, and we just had to accept it. And the biggest thing was that you had to put on PPE before you could do anything, because CPR and even defibrillation and certainly intubation, are aerosol generating procedures. Um, and you risk everybody in the surrounding areas. We got a lot more specific, and I think most hospitals did too, about limiting the rescuers to those who are absolutely needed. One of the things about hospitals is everybody shows up. Um, and sometimes that's good, but in this particular case, it was could potentially be very dangerous.
Mhm.
So that was another big emphasis. Um, and we had probably um, survival from cardiac arrest declined during the pandemic. Now, part of that was the disease itself. It was a bad disease, and a lot of people died. And it took a long time to learn how to take care of those patients, especially before we had vaccines. Um, and but there were some problems. I mean, it took that extra time to put on the PPE, and we just had to accept that because of the risk to our providers. We've always kind of been a little concerned. One of the first things is to make sure that the environment is safe. But suddenly that became a huge issue
Mhm.
during the COVID pandemic. And I think that we have continued a lot of those policies. I think we're far more aware of, putting on gloves, putting on masks in those situations. Just in general, just do it. You may not have to put on the full gowns and that type of thing, but just be more cognizant of those kinds of risks to our rescuers.
Mhm. Do you think that there have been, did it advance the science in a way that it might not have if we didn't all go through that experience?
Well, I think in general, COVID advanced the science. We learned a lot about viral disease. We learned a lot about vaccines. Um, and I think it's a little hard to say for actual cardiac arrest as to how well that advanced the science. It did change our perspective a bit, um, but I think we got better as we got better at treating COVID in general. Not as many for example, um, just realizing that the acutely ill patients needed to be prone instead of supine. Now that caused some problems for CPR, and we made we said if you have to do CPR prone, do it. Um, I'm still not certain that we know that's as effective um, as is supine CPR, but we also knew that if you turned them over, it took time, and their lungs may not tolerate that at all, and if their lungs are not going to tolerate that, then you're not going to have a successful outcome.
Yeah, it's really, really interesting. Um, how was it getting information during that time as well? Like, for all other guidelines and, the annual reviews and updates, you have tons of studies that you're looking through, but this was something that you were like having to make decisions here and now. How are you getting the information to be able to make those far-reaching decisions?
It was a bit like drinking from a fire
Hmm.
hydrant. There's no doubt about that. I mean, the number of publications that had to do with COVID was, in that, especially that first year or two, they were immense. And a lot of the medical journals um, prioritized articles about COVID because there was so much to learn. We worked very fast on the guidelines. As I said, there were three um, that were published during the uh, pandemic. And one of the things that we learned the hard way was that the publication process itself, because that takes so much time, can actually be a detriment because things were changing
Mm.
so fast. And I'll give you an example. Um, in the spring of 2021. If you recall, by this time we had the vaccine and people were getting vaccinated. And it seemed like the um, pandemic was resolving. I don't think we ever thought it would resolve or the virus would ever go away, but these huge numbers of people getting ill did seem to be going down. And so the Heart Association in that spring um, prepared some guidelines that were not published until October. And if you remember, by October of 2021, things were on the upswing again. And so those publications, that publication that was prepared in the spring, but not published until October, was out of date the day it was published. And we didn't quite realize how significant that was until we started hearing, well, we can't follow these guidelines because they're just not appropriate right now. And it mostly had to do with PPE. Um, uh, and so literally in January of 22, we did 3 weeks, and I am the first author on that publication. Um, and we set out new guidelines. We published it in 3 weeks that were more appropriate for the stage of the pandemic that we were at. And so we learned the hard way on that in the middle of a worldwide pandemic, you have to act fast and you have to be ready to make changes as things are happening.
I'm curious, I assume there's some kind of peer review process as you're in it.
I have to say, yes, it is a peer reviewed process, and we do get comments back with a different viewpoint that we have to respond to. And as someone said, it always seems a little unusual to have a peer reviewed process for guidelines where people have worked for years on it. But on the other hand, and this has been my experience with my own personal publications, it's always a bit better when someone else with a fresh viewpoint or a different viewpoint takes a look at it and makes some recommendations about changes. When we published those 2022 guidelines at the end of January, it came out in Circulation Quality and Outcomes. And we had the cooperation of the editor, and he set up in advance some peer reviewers who were willing to provide very fast peer review. And I think they provided it to us in probably about 48 or 72 hours. I can't quite remember. And then we made the changes and got it back to the editor in also a very short period of time. Because I think we started working on that document literally. I spent all New Year's Eve working on it about then. I remember I think I sent the first draft out at noon on New Year's Eve or something like that. But it was published the last week of January. And it has about 50 authors. Wow. So I got a lot of comments. But people recognize the need. The editor, the journal recognized the need. The Heart Association and its staff recognized the need. The volunteers recognized it, and the peer reviewers recognized it, that we had to work fast. And people did.
Oh, I'm sure you guys don't get much opportunity to hear gratitude for your roles, because I think you're probably more hidden figures within the system. But truly, when we were working in the fields and our peers and our friends, any tidbit of guidance, support, a light that there's a way to do it the best way, the right way, was so important and so useful. So those hours and tears and blood and sweat really did mean quite a bit to those on the ground. So thank you.
Yeah. You're welcome. Thank you so much for that.
Well, we've taken a lot of your time already. I'll think about wrapping up soon, but I do have one or two more questions if that's okay.
That's okay. Go ahead.
I'm curious, in the general sphere, public clinicians, what are misconceptions that exist about what ECC is and does?
You mean like in the general public?
Sure, or within the medical community itself.
Well, I think there are two different, and they're the opposite. I think that within the general public, they think right now that CPR is more successful than what we currently see. I think it can be more successful, but because of a lot of barriers, people not doing CPR, not utilizing the AED, those kinds of things. What they see on TV, we know is not very accurate, and that gives people the wrong impression. In the hospital, if you're not really up on the CPR literature, I've heard people say, well, this isn't going to do any good, and we're just wasting our time. And indeed, in hospital cardiac arrest has a much better outcome than out of hospital cardiac arrest, probably because you immediately have professional rescuers. You have, notification systems within the hospital, quick notifications. Many patients are high risk patients for sure are being monitored. There's the stat pages and that type of thing, and it really has a surprisingly good outcome. But I will occasionally hear people say, "Oh, this is, it's not going to work." Um, Sometimes that's patient selection. I think you do have to be um, a proactive. Obviously, a patient who has widespread metastatic cancer, there needs to be a discussion about the end of life goals of that patient and that family, so that futile CPR is not done.
Hmm.
Um, those are hard conversations to have, but they benefit everybody. They benefit the patient. Patient is allowed to express their wishes. Benefits the family because they know what may happen, and it benefits the staff because they know how to handle the situation.
Hmm. Yeah, I've lived that experience too many times in my career of not having those conversations ahead of time, and then just the the pain caused to all. Um,
Mhm.
that's so important.
I do have kind of another question.
Sure.
Um, what excites you coming in October? Like, I know that you can't give us any tidbits of what's coming out, but like, what sort of things like are you like looking forward to see?
Well, for the first time in many, many years, I was not on a writing group for one of the big chapters, like pediatrics. That's obviously my main goal. I've seen some of it, but in no way have I seen all of it. So to a certain extent, this year I'm a little bit like you all. I don't know for sure where we're going to come down. I do think one of the biggest things will be double sequential external
Mm-hmm.
defibrillation. That's been a huge discussion in the adult community. That's not something that um, we've discussed in pediatrics because it's not common in adults, and it's not common at all in kids. And in kids, it's kind of hard to do because you don't have enough chest space or enough real
Yeah.
estate,
Right.
as we say, to put all those pads on. But I think that's going to be a good thing. I think there may, I don't know. I think our emphasis on early epinephrine, we've clearly made that, and I think the data to show that early epinephrine is important is getting stronger, and so that may be there. I don't know. I'm excited. I'll be in Rotterdam when they are released, so I'm looking forward to it.
Awesome.
Amazing. Well, we've got it on our calendar. We're looking forward to it.
Good.
And I'm sure that, you know, even if we reach a few people that piques their interest too, because these are questions I've had for years. I really haven't known how it goes. And so I'm so fascinated and excited that I have a little bit more background knowledge. And frankly, I've always respected it, but I just have so much respect for
Mhm.
the efforts. And we didn't really hit it, but the fact that it's so much volunteer work and people
Yes.
just giving their time and their energies to better the health of everyone in our country and then in the world, because obviously AHA is leading the charge in a lot of the research.
I've sort of, within the Heart Association, I've been in two spheres. One is the pediatric cardiology community, and one is the resuscitation community. And I'm not criticizing my pediatric colleagues at all, because they are very passionate. But I think the resuscitation community they are some of the most passionate people I've ever worked with. From out of hospital rescuers to, the highest of critical care. That's why we do it. We have a passion for it. We know that we can improve things, and so that's why we work hard at it.
Well, thank you for sharing your passion with us. We are equally passionate and hope that the fire spreads to everyone, and passionate about resuscitation and the difference that every individual can make. Thank you again for your time, Dr. Atkins. This was wonderful.
Thank you.
Thank you. I appreciate the opportunity.